Welcome back, everyone, to Pain Science in the Trenches, where evidence meets the realities of clinical practice. For those of you who are new here, this webinar series is all about bridging the gap between where pain science is right now and what it actually looks like to apply it in the clinic with our patients. Each month, we'll sit down with a pain specialist and who's actively applying pain science in the clinic, and we'll hear all about how they apply it to the unique populations that they serve. Today's conversation will focus on pediatrics and adolescents living with persistent pain, POTS, EDS, and other chronic conditions. Too often, these patients and their families are left searching for answers or just feel like they're trying to survive from day to day. Joining me today is Dr. Jennifer Welter. She's a physical therapist, fellow in pain science with a focus on pediatric pain, an evidence in motion faculty, author, and founder of Thrive Whole Person Health. With more than 20 years of clinical experience working with youth and their families, Dr. Welter has become a leading voice in integrating pain neuroscience, lifestyle medicine, and whole person care into pediatrics and adolescents, patient care, and pain management. She has co-authored Ouch, Why Do I Hurt? A children's workbook and guide to understanding pain. She's also the founder of the Thriving Teens program, which is a teen-friendly, family-centered lifestyle medicine program for teens struggling with persistent pain, POTS, EDS, and functional neurological disorders. Today, she will be helping us understand how we can better translate pain science into meaningful care for young people and their families. So good morning and welcome, Jen.
Good
We're
morning,
so excited
Christina.
to have you here.
Thank
I'm
you.
yes, I'm really looking forward to diving into this topic with you today.
Wonderful. Thank you for having me in that lovely introduction. I am very excited as well. I think this is a wonderful idea of how to translate pain science into the clinic.
Yeah, we can't wait for all of your clinical insights that you have to share with us today. Um, so for today, let's start at the beginning. What led you into specializing in pediatric pain, and how did pain neuroscience become such a central part of how you such a central part of your clinical approach?
Um, I think honestly, I've always been pretty fascinated by the brain and by human behavior. And I came from a family of educators. So I was probably, kind of destined to work in this space. And I just didn't know it way back when. But I was really very fortunate. Forever ago, when I was in PT school, to have professors like Steve Schmidt and Ben Boyd, individuals who were already incredibly passionate about pain science. And they really introduced me to those fundamentals early on. And this was a long time ago. This was when pain science was really not all that common in PT programs. So, I count myself very lucky to have gotten that early exposure when I look back on it. But, at the time, as I was going through my early education, I knew I wanted to work in pediatrics. That was really my passion. So I don't think I really connected those dots quite yet of how that basic fundamentals of pain science would working with kids and with families. But the more time I started to spend with families, the more I started noticing these patterns, right? That how a family reacted to a child's pain experience mattered, their daily habits mattered, their parents' own experience of pain mattered, and certainly the amount of fear that a child or even their family was experiencing, that really mattered. So all of those things started to kind of connect the dots. And then very early on, I was still treating both adults and kids in the clinic. And somewhat by accident, I wandered into a lecture by Adrian Lowe at CSM. I think it was like a year or two out in clinical practice. And that kind of changed everything for me. Suddenly all these little pieces were coming together of what I was seeing in the clinic and,
Yeah.
what I'd seen in school. And then that kind of, I really connected with how Adrian presented these simple, very patient-friendly ways of communicating pain science. So it fit well into how we already talk with families. And that's, kind of how I started to see things differently, and there, I just went on and kind of gobbled up as much information as I could and realized that, hey, there was a lot of really fantastic information out there based in adult care, but not necessarily focused on pediatrics. So I was doing a little bit of just kind of creative application. And I think that's still what keeps me excited is that idea of being able to, apply it to this different population than what we typically see, and starting to advocate for this being applied in peds because it
Yeah.
works really, really well, right? It works. It's
Yeah.
it's such a wonderful approach and very family centered. And then I think the other thing that really keeps me, in this is that unfortunately we still see a lot of this pathoanatomical approach to kids in pain, right? There's this somewhat of this mindset that pediatric pain is different, right? That we're
Yeah.
still in this kind of find it, fix it approach, mind and mindset. And that's really still floating around out there a lot. And so I'm very passionate about trying to shift that conceptual framework and, the skill sets that surround how we manage, families that are going through this pain
Yeah.
experience, right?
Yeah. Yeah. That's such like an important point you made about like, especially about how like we're working with kids and their families. And it sounds like that experience really shaped like the lens you practice through now. So how does the biopsychosocial framework look in practice with pediatric patients?
So that word always, it's such a big
Yeah.
biopsychosocial, right? And I think a lot of people, when they hear it, they kind of imagine this really abstract, almost academic model of how the things we have to look at. But when you're talking to kids, you're talking with teenagers in particular, it's kind of impossible not to practice in that lens of looking at all the things, right? They live in these layers of their family system and their school environment, their friend groups, and I think more than anyone, they're really acutely aware of this very rapidly shifting world that's around them, and then also their own internal world that's really rapidly evolving and shifting. So it's kind of a natural way for me to address managing symptoms with kids because kids aren't just dealing with pain, right? They're dealing with pain and what it means to their friendships and their sports and their independence and even their sense of self-worth. So, even if we're dealing with not a chronic pain situation, even if it's an acute situation, their biology isn't in a bubble. As I tell them, they have to really address all the puzzles, all the pieces to that puzzle, right?
Yeah, that brings the biopsychosocial framework to life.
Yes.
Um,
Yeah.
so when you zoom out on or zoom in on what that actually looks like in practice, what sort of like presentations of nocioplastic symptoms do you see most common in kids and teens and what are the biggest challenges in these populations?
Yeah. I think the biggest thing to recognize is that this really isn't one population as much as it's this kind of ever evolving group. And so, for instance, in young kids, we are seeing, predominance of musculoskeletal injuries. Oftentimes they're secondary to trauma. And depending on the child, depending upon the parent's response, even the context that the injury happened in, that can start to instill some of that fear avoidance and family worry, and that can, predispose them to shift what might be an early of just nociceptive injury into more of a nociplastic situation pretty quickly. And, We do see nociplastic symptoms in young kids. I think we used to think that it was all about issues in their tissues. We do see them. They tend to show vaguely, tummy aches, headaches, aches and pains all over, sleep disruption, even school anxiety. So we see them in this kind of vague context.
Yeah.
And we know that, pediatric pain in general is kind of under recognized, right? If you look at the literature, over 40% of kids experience pain on a weekly basis, which is a
Oh,
huge number,
that's a
right?
lot.
It's a
Yeah.
huge number.
Yeah.
And 20% of kids are affected by chronic pain in some way. So, that's much more than I think if I would go out and survey anyone that they would imagine. I think the thing that though it is always most kind of alarming and makes me want, to encourage people to have this kind of call to action to manage pediatric pain is that over 70% of those kids that are experiencing chronic pain when they're kids carry that experience of pain into early adulthood. So right, there's such a downstream effect to the way we're engaging with and addressing pain early in the lifespan. Um, and then as they get older, right? So the things that we see is as puberty hits, as they hit those teen years, we do see a pretty drastic increase in a number of different nociplastic presentations. Yes, we do still see some of these multi or musculoskeletal based pain presentations, back pain, knee pain. But number one and number two are headaches and abdominal pain. So, you're seeing that, you're
Yeah.
seeing, other symptoms that are more system wide. And then the
Mhm.
other thing we're really getting a greater awareness of and a recognition of is some of these other related comorbid conditions like POTS, dysautonomia,
Mhm.
in the adolescent population. And I tend to not refer to it as POTS. I tend to refer to it more as dysautonomia because I think the
Yeah.
POTS label, as much as that's
Yeah.
known, really overemphasizes the tachycardia component to it, whereas we're really aware that dysautonomia is a system-wide impact on the autonomic nervous system. And it's very common. The most common time for this to occur is during puberty, during the first couple of years of puberty.
Yeah.
And right, and up to 1 out of every 100 kids is experiencing some signs of dysautonomia. So it's really not uncommon, and
That's
it
yeah.
comes along with nociplastic pain, right?
Right. So if we
Yeah.
can like get on top of like our young people in pain, like maybe we can bring down that 70% of people that carry over into that young adulthood.
Exactly, because really, all of these different pain conditions that we're seeing in young people, they're just kind of different manifestations of of their nervous system not being able to regulate, and it's kind of lowered the threshold for showing these symptoms. And if we can get on that now, right? Imagine the
Yeah.
toolkit we've provided and the shift in their relationship with the pain experience that they now have as they, carry on into adulthood. So.
Right. Yeah, that was so important. So that naturally leads into something I'm really curious about. How do you adapt pain neuroscience education for different developmental stages? So, like, for example, a 9-year-old versus a 16-year-old, or just even different neurotypes.
Yeah. This is where it comes back to that they aren't just one population, right? That kind of
Yeah.
misnomer, the pediatric population is that they're this ever evolving group. And so the most important thing I would say is that you have to really understand the cognitive, emotional, and just developmental stage that the current patient is in. So all the way up to if we start back at the beginning, our little teeny tiny babies, we can start that soon. And that sounds crazy, but
Yeah.
neonates, little babies, they don't have typical pain behaviors. They don't have a social expression of pain. So we're
Mhm.
looking in terms of how they're experiencing pain is more their physiologic changes, right? What's happening to their vitals, and those are kind of the tells that they set off, and but the good news is that those pain pathways in very, very early infant times are extremely plastic. So how we engage with them and during painful or potentially painful experiences really has a downstream impact that's really powerful. And so in those cases, how do you do pain neuroscience on a neonate? Well, it's the parents, right? So the
Um,
environment, the context that they're in, the healthcare providers, right? How are we talking to the nurses that are doing their heel sticks, or how are we engaging with that infant and making sure that we're calming their vitals when they're having a circumcision? Like all of these things really do matter to pain neurophysiology. So we can really even start that young. Um, if you think about your toddlers are, they're all about the sensory world around them, right? They feel things and they
mhm.
do things. And so, how you would engage a youngster with pain is less about language, is less about explanations, it's less about metaphors because they don't get those yet.
Right.
It's more about um, experiencing it, right? What are they watching in the people around them and how calm they are staying? How are they responding? Is their first go to, children's Advil, or is it, hey, pleasant distraction or other things that might be able to help to mitigate their pain experience? But then, if they get a little bit older, you're looking at like a school age, then they really are more hands-on, right? They want to do it, right? Young kids, they
Yeah.
want to learn by doing. They don't want to read about it. They don't want to watch it. They want to do it. So you can start with some of these metaphors and simple stories, start to give them some
Mhm.
of the why behind what their body's feeling. We start
Yeah.
looking at those mystery bruises and going, well, where did that come from? And why didn't your body tell you about it? And their natural curiosity lets you have those conversations. But honestly, ideally, if you can get them engaged in doing something, right? Like as something as simple as a worksheet or an activity, or hey, isn't that really interesting when you're listening to your favorite songs or singing your favorite songs? Maybe it doesn't hurt so much. So they start to
Right.
get that idea.
Yeah.
Right. And then
Yeah.
our teenagers, right? I think that's what everyone's waiting to hear about. They're the
Mhm.
tricky ones. And they're even of themselves. So they're changing so rapidly that each one of them is a little bit different. But in general, you can start to use more metaphor and story. Um, you have to recognize that it is the nature of teenagers to really question you, to challenge you. So you can use that to your advantage to really let them lead the way in terms of curiosity over what they're experiencing. And then anytime that you can make pain neuroscience social for them, this is really key because that's their greatest influence. It's no longer parents, it's no longer healthcare providers or teachers, it's now their social group. So anything you can do to engage them socially and kind of active strategies to manage pain is really important. Um, you mentioned neurotypes, which I'm glad you did because I think that's what we're beginning to understand more and more, right? Is that this isn't so simple as an age-based developmental stage, is that we know that our autistic and ADHD populations consistently have a higher pain burden, regardless of age. And if you compare them to what we consider typically developing or non-neurodivergent groups. And this is the case for pain. This is the case for our hypermobility syndromes. 10 to 15% of our HSD and HEDS patients are identify as autistic, and about 30 to 35% of them identify as being ADHD, which is significantly higher than those that we see in the general population. So we know we're going to be engaging at a higher frequency with people with neurodivergent phenotypes. And how does that change how we use pain neuroscience education, right? How do we communicate differently? How do they learn differently? How do they choose to want their care? How do we engage with, those of us in the world that um, experience things differently, right? So that might mean changing the metaphors that we use. It might mean using more concrete language. Sometimes I will even get more technical if that's how they tend to learn better than choosing to just utilize our typical metaphors and stories.
Yeah. Yeah, that's really helpful, especially like it basically just comes down to like thinking about how they process the information depending on their age or neurotype is
Yeah,
how you're
they
going to get through to them.
and that really comes from that communication, right? Listening first, knowing what that they want, and they'll tell you. I mean, if you listen well enough, they're going to tell you what how they
Yeah,
learn and how they want to
right.
engage with the information. Um,
Um, so I'd love your thoughts on something I think that comes up all the time. Is how do you explain central sensitization on a child or teen that's in a way that's developmentally appropriate or doesn't feel dismissive, to avoid having like that pain science framing come across as it's all in your head or to the patients and families.
yeah. Yeah, the pain talk, right? Like, oh, here we go again. Someone's going to tell me it's all in my head. Um, Honestly, for me at least, that starts well before I kind of dig in and decide to talk about pain, right? It has to start with developing trust with these families, because I think that in general, when a child of any age, in particular teenagers, when they've been struggling with these symptoms for a long time, it's a really common theme for them to feel kind of unheard and invalidated. Um, and not to mention the fact that just by the virtue of a young person with a healthcare provider, there's this kind of natural power differential that they feel. And so it's important for us to start that process of educating first by just stepping back and listening, validating their lived experience, making sure that we're getting that really good, thorough patient interview, really understanding where it is they're coming from. Because validating that lived experience is just as much of a clinical intervention. And it builds that foundation of trust that you're going to need for you to say, hey, are you open to us discussing what pain means and what I understand of pain. So it opens the door to that curiosity and lets you hopefully step through, because that relationship, that therapeutic alliance, everything that we talk about, trust is super important, especially with our teenagers. Because they've probably been to 2, 3, 5, 20 different providers that talked to them instead of talked with them and didn't make them feel heard. So if you can start that process of them understanding, what's happening to me, what can I do about it? How are you going to help me with it? That's going to help. And then you can step in and you can start slowly shifting that narrative towards, the idea where you're sore but safe and that pain doesn't equal damage, and then they'll begin to trust that, okay, this person cares, they know what they're talking about, and if they give me some kind of concrete examples in my life, then I might buy in, right?
Yeah, that's such an important balance to get right, especially like when you're making sure um, we're not dismissing the patients and their families and like, and what they're actually like dismissing what they're actually experiencing. And I think where things get even more nuanced is because with conditions like EDS, there's real structural and physiological factors at play. So, how do you balance pain science education with those structural concerns of EDS?
Right? I mean, because there are
Yeah,
issues in the tissues, right? That's a great point, right?
yeah,
But if we think about it, even if you aren't working with the hypermobile community, even if you aren't working in pediatrics, if we really think about it, um, the vast majority of patients that we see in the clinic, it's never a completely nociplastic mechanism, or at least not the vast majority of the time. There are always some small, even small sliver where the tissues are involved, right? And and that way it really doesn't make hypermobility syndromes any different. However, right, I think we can't discount the very real connective tissue differences, right? And the very real kind of combination. I'll talk to one of the classes that I give and the way I communicate with young people with hypermobility is that we separate those different types of pain, right? The idea that you might have some tissue issues, your nerves might be inflamed from all that additional potential range of motion that you're putting them through or staying in end range for a long period of time. So they get, irritation. And that, yes, there is definitely that sensitive security or the sensitive alarm system. So, we look at this in terms of what different signs and symptoms, what different things you're experiencing might indicate different things to you, right? And what that might be telling you about what's happening right now and how to best manage your symptoms. But the other part to think about is that I think we've come a long way with our understanding of what hypermobility is, right? So we used to think of it as just being a bendy body, right? And then
Yeah.
now I think we have this very good and evolving understanding that this is not just about connective tissue, that this is a multi-system experience, right? Yes, connective tissues are involved, but it goes a lot deeper than that. So yes, we discuss, the differences in connective tissue. We discuss the differences between the potential of being hypermobile versus the fact that that doesn't necessarily mean those joints need to be unstable, right? And that we begin to layer in the ideas of all the different layers of protection that your body has between the structure, and that's where we can start talking about. And then we have this fabulous alarm system that helps protect as well, so that they can shift away from thinking they're kind of broken and instilling that their body really does have all of these fantastic protective measures. They just might be doing too good of a job of protecting them at times. So
Right.
then we can start to talk about, how the nervous system might be involved. How their immune system is most certainly involved, right? Some of the latest literature that's coming out about hypermobility syndromes is showing genetic markers associated with pain sensitivity, which we could probably have guessed, and immune dysregulation. So we can start to say, hey, we have to make sure that we're regulating your nervous system so that your nervous system can then communicate effectively with your immune system. And then your immune system doesn't get hypervigilant or overprotective, just like your nervous system can.
I think that's so empowering to be able to give that patient, like, who is going to have pain, try and like kind of decide what level we're at and what they can do with that so they don't immediately go into a panic.
Yeah,
That's so,
absolutely. Right?
um,
Like start to
yeah,
give them that power back
yeah,
because
mm,
we see it, especially in young people, whether it is that they're experiencing a variety of just chronic pain conditions, hypermobility related, dysautonomia, whatever it might be. One thing we know about kids is that they love their TikTok and they love their social
right.
media. And that can be a source of community to them, but it can also be a source of some somewhat less than accurate information. And there's a lot of feeding into the idea of this being something out of their control. So the more that we can really give them that sense of control back, whether it's modulating a nervous system, helping to support their immune system, helping to support their GI tract, all those things, all those Peony Plus approaches is really empowering to them.
So now when you have like this complex presentation, like EDS, parents are often, I would think, carrying a lot of fear and uncertainty themselves. So how do you involve the parents without letting parental anxiety become a barrier to progress?
Yeah, that's when you go into pediatric practice, I think you think the scariest part is dealing with the kiddos. And then it takes you probably about 2 days in clinical practice to realize the biggest challenge is that family dynamic, right?
Yeah,
And so, we know that there's no patient population where the effect of family is more evident than in kids. And those parents can be a really wonderful and supportive and provide this kind of adaptive environment, or they can kind of challenge their ability to do active strategies to imagine, a way past this pain experience. So, we know that chronic pain is in kids, it's strongly associated with the pain experience in their parents, and the amount of catastrophizing in those parents.
Yep.
So we can't ignore it, right? We have to, when we're focusing on helping a young person, no matter their age, we have to also emphasize that education for the family unit, and do it as preemptively as possible and as many times as possible so that we start to hopefully mitigate that potential for those downstream ramifications. So this is a time where pain science isn't about just chronic pain or chronic conditions. This is about how do we educate a family to kind of preemptively prepare them with more adaptive strategies to help. But because we know if the parents, if the caregivers, if they're not confident in their child's ability to manage pain or what's going in their child's body, they're more likely to engage in these kind of overprotective strategies, right? They're more likely to encourage them to rest, for them to stay home from school, to use pain medications. So the more we can really educate and empower the parents, and lower that level of anxiety, the more they're going to then shift from kind of instilling maladaptive pain coping strategies towards developing some more adaptive, good long-term approaches that are going to serve their kids well. So I address it pretty straight on. I validate it. It's a completely normal and understandable thing for a parent to be anxious when their child is in pain. And so coming back to the idea of making them feel heard, developing their trust that you have their child's best interests at heart, that can calm things down significantly. And then, really listening and collaborating with them. And then, I actually teach a class called Focus on Family, where we specifically talk just with parents and caregivers about what are great ways to support your child, what are ways to maybe give them some autonomy depending upon
Yeah.
their age, so that you're starting to help them. And then,
Mhm.
as we know, the majority of young people that are experiencing chronic pain conditions have parents that are experiencing chronic pain conditions. So
Oh,
if we can address their parents' pain, that's going to have that downstream positive impact on their kids.
wow. Yeah. And I mean, when it comes to the parents, I'm sure all they want is to see their child comfortable and they just want to help their child. So I'm sure the tools, like giving them the tools, they're so appreciative of just being told like how they can help their child.
Yeah.
And
Yeah. I I had the unfortunate yet fortunate opportunity as a young mom myself to go from being a healthcare provider that takes care of kids to suddenly being thrust into being the parent of a child in pain who had a very traumatic femur fracture, an unstable femur fracture. And I
wow.
would say, thankfully all went well and things were good, but it was a
Yeah.
really in retrospect, at least, a very wonderful perspective to see how, as a parent who's understandably anxious, holding their child's femur together at the grand old age of 2, that
Yeah.
the behavior of the calmness of the communication strategies used by the emergency personnel, the people in the emergency room,
Uh,
the
yeah.
orthopedic surgeons, all those people involved, they had such a dramatic influence on my comfort and confidence in what was happening. And then the calmer
Yeah.
I was, the calmer my toddler was. So we are
True.
so the calm, confident, and competent, um, you know,
Yeah.
perspective that we can give makes a big difference.
Difference. So once you navigate that family side of things, there's also the challenge of then helping teens buy into this process. So teens can come across as difficult or just disengaged. So how do you build a therapeutic alliance or get them to actively engage with their care?
Yeah. I love teenagers. They are such fascinating young people to work with, but they really can come across at first glance as being a challenge. But I think the first thing that makes me really impressed by them and their resiliency is that they are navigating this incredibly complex developmental phase in their life. Like they are in this transition between being kids to being adults. They're neither right now. They're kind of in this limbo. They're having all these physical and hormonal shifts, all these emotional shifts, the social changes that are occurring in their lives. And they are in this natural period where they are fighting for their autonomy. I think I got two of them at home right now, and you see it every
Yeah.
day, right? Where
And I think we can all
they
remember being teenagers.
right, right. They're
Yeah.
like,
Yeah.
I can do it. It's, right with that butting of heads that invariably occurs, because they have this brain that's wanting to develop this sense of autonomy, but there's this frontal lobe that's still in process till their mid-20s, so they don't always have that consistent executive function to support this desire. And that can make it sort of tricky for them to engage in care, especially on a consistent basis. So it is this unique group of individuals, this unique situation that we find ourselves in. But I think I find if I can kind of shift my own mindset and recognize that, non-compliance, disengagement, those are really just developmentally normal at this age, right? This is, what we should expect, that they want that independence, but that they don't fully have that system in place yet that lets them plan and regulate and, function in a consistent manner. And that we have to recognize that their emotions, their peer influences, their motivations, these are going to wax and wane, and that we kind of have to ride that wave with them to some extent, and it kind of should shape how we care for them. And that there is this natural bit of distrust, especially in healthcare, right? Especially with these kids, they're going to see a bunch of people. They might have been felt dismissed. A lot of healthcare providers will be communicating more with their parents versus them as the drivers of their own lived experience. So we have to help them again with that trust and that therapeutic alliance. Teenagers are really smart, and they know when you are talking at them versus talking with them. So they want you to be authentic. They want to feel that you're understanding them, that you're not just managing them. And then, so I spend a lot of time listening, right? I try to meet them where they're at. I try to, understand what's important to them and not just what matters to their parents, and that even comes down to where I position myself in a room and how my body language speaks to me caring about their perspective as much as I do their parents. And recognizing that their goals are different, right? We might be focused on symptom reduction, but they probably are more focused on how do I get back to school, or how do I get to go hang out with my friends, right? The impact of their symptoms on their participation, their social life, what matters to them is probably more important than the symptoms themselves.
That's a good point.
Right? Like
That, yeah.
that matters. And so getting them back to doing the things that matter to them is important. And then our language matters, right? So we have to make sure that when we're communicating with them that it's salient to their lives, right? I'm not going to talk about mortgages or work stresses with a 15-year-old. I'm
Yeah.
also probably not going to focus my communications around long-term health risks or planning in the future. Their brains just can't wrap around the idea of a long-term plan. It has to be, their pain education, their symptom, strategies that we use to help calm their symptoms down. They have to be about the now or maybe the tomorrow, but they
Yeah.
really have to understand how it's going to impact their life now. Um, and then the other piece I would recommend with working with teens is that family does still matter, right? They want this autonomy. Family does still matter, of course, because they are still relying heavily on this family system, and the family is, of course, the how adaptive their household is and the habits that are happening in a household matter. But I try to help shift the parents' mindset into an idea that they're no longer the managers or controllers of their child's care as much as they are the coaches and the
Yeah.
example, right? So
Mhm.
let them, kind of create an environment where the healthy choice is the easy choice for their child. And that tends to work a bit better than I don't get as much of that butting of heads as you sometimes will.
Yeah.
And then because of that, the good news is that even though they can be a little tricky, they're also really neuroplastic. And so you have a
Yeah.
lot of opportunity for making good impact with them if you can get them.
We love that as physical therapists. Yeah. So this really highlights like how important the therapeutic alliance is, especially when the kids and teens, I'm sure, have been struggling for a long time. I imagine trust becomes even more important when you're helping them gradually face movements, they activities or situations they've started to fear or avoid. So how do you use graded exposure and how do you build like a fear avoidance hierarchy with a child?
Yes, absolutely. I mean, I think that's imperative that we start getting them to do the things, regardless of the age. We need to start getting more active strategies, and we can scaffold that on this understanding, the modifying their understanding of what's happening in their body so that it gives them a window that reintroducing, whether it's movement or going to school or whatever things that are triggering to their symptoms, if we can start to reintroduce those active strategies, it helps over the long run. We know that the evidence really supports that in spades. However, that can be very scary if we haven't started by reconceptualizing it first. So, scaffolded on this idea of sore but safe, and that slowly introducing things is important. With the littles, we talk about things like being a pain ninja, where we can sneak up on some of the symptoms and then we sneak away. The idea is that ninjas don't avoid, but they
Um,
do things in a careful manner so that they're kind of, don't overwhelm the system. So we'll use, a lot of, brainstorming or even coloring activities or ways that they can control how much or how little that they start to re-engage in activities that might be difficult for them. With older, with our teenagers, we can start to have those, more reasonable conversations about, hey, this is why it's triggering symptoms. If they have a good understanding of the role of their autonomic nervous system, so that when something does come up, when they do get a flare, when they start to re-engage in something, we can say, that's interesting. I wonder why that happened. What about that is making your body's alarm system want to protect you? And we can start to shift them away from, and they're like, of course, they know all the things. And so they're like, well, that's not dangerous. It's not dangerous for me to do this. So, and let them kind of come up with their own kind of structure to that graded exposure to get back to doing the things that they want to do.
yeah. Um, yeah, I think that highlights just such a fine balance between alongside the graded exposure, there's also like the challenge of helping kids regulate without unintentionally reinforcing fear or avoidance. So how do you teach pacing, which is such a huge part of the pain neuroscience education approaches, without reinforcing avoidance behavior? And do you use things like biofeedback devices or heart rate monitors for those teens with POTS?
Yeah, great question. Teenagers in particular tend to, and kids of all ages really, they tend to fall into two categories. They're either the totally avoidant, or they're my boom busters, right? Where they're just like, I'm just going to get it done and pay for it later. And so starting to help them understand how to, go from the Great America roller coaster down to just a gentle little kiddo roller coaster when it comes to their symptom and fluctuations, and helping them kind of problem solve and understand the idea of what their triggers are, how to not avoid them, but how to, pace themselves throughout the day is important. A few of the strategies that I find most effective for that, especially for adolescents, is developing some kind of mini habits or changing kind of their daily habits, right? So instead of utilizing kind of avoidance, we really start to try to create these little micro habits that start to re-engage them in some of the activities. Because I talked to them about, the more routine something is, right, the less it activates our body's alarm system, because it's not novel, it's not new, it's not different. Our body's not going, wait, what's that? We haven't done that before. Maybe I need to protect you. Maybe it's a threat. If it's
Right.
something we're doing a little bit every single day, and maybe we even connect that new activity, that new habit to something you already do. It's going
Yeah.
to help take some of the motivation out of it that waxes and wanes in this population, but it also makes it feel less threatening to our nervous system, right? Like, you're going to
Yeah.
stand it when you're brushing your teeth in the morning, which hopefully is a daily habit for them,
Right.
doing a couple of their active movement strategies, or every time they, sit down in a new class throughout their school day, they're going to take 2 mindful breaths, or whatever tiny little strategy we can start to insert, so that new things that we're adding, new strategies, don't feel like they have to dive in the deep end. They're just doing little bits. So it helps them manage their time and their energy around it. Um, you mentioned biofeedback tools, and that's a great topic, especially for this age range, because if any of you go on social media where they spend much of their lives, there are a myriad of different biofeedback tools that are being marketed to this age range, to chronic conditions, and we have to be really careful with that, right? So one thing we know, especially in the POTS population, and also in chronic pain, anytime that someone is having central sensitization, they have this hypervigilant body awareness or interoceptive sense. And so if we are constantly feeding into that interoceptive sense, we might be creating that hypervigilant kind of vicious cycle. So I will typically not recommend all the wearables, the Apple Watches, the Fitbits, there's every different variety that tracks heart rate, that tracks variables in real time,
Yeah.
in most cases, because you have to be really cautious that you're not shifting them into a more hypervigilant state.
Yeah.
However, they love technology, and you have to prove that what you're doing is not just woo woo, that it actually is making a difference. So there's a
That's
few
very cool.
exceptions to that, right? I
Yeah.
love using heart rate variability as a method of really recognizing how much they're modulating their autonomic nervous system and their vagal tone. So if I
True.
can, I'll use a heart rate variability tool that actually is something that we modify and we utilize in real time. Instead of just getting a score, you're
Yeah.
actually seeing, oh, the activities that I'm doing, they're actually,
Like,
changing my heart rate variability for the better. And the same goes for sleep. So sleep is a hugely impactful part of the P&E plus, process with young people, as their
yeah.
sleep tends to be very dysregulated. So if I can start to show, hey, you've done all of these different sleep strategies, we've been working on your sleep hygiene, and look at this, look at the amount of deep sleep you were able to get, this night versus a week ago. And so then that can really kind of be empowering to them that they've made a tangible change.
So like using these wearable devices more as like motivation to like, oh, what I'm doing is helping me get better sleep. So I'll continue doing that.
Yes.
Or like helping
Yes,
my heart rate variability. So it kind of
exactly.
motivates them to kind of keep those practices.
Exactly. Versus
Yeah.
I think there are some on the market that are really more focused on, oh my gosh, your
Yeah.
your heart rate is high. This tells you
Yeah.
you should stop right now. That's the
Uh-huh.
mindset we're wanting to disrupt, the idea of putting the brakes on because of symptoms, as much as it is trying to, how the positive and proactive approaches that we're engaging in can make a positive difference in,
That makes
those
sense.
wearable parameters.
Right. That's helpful. That's a helpful way to think about how we can use these because I think, yeah, they'll, like you said, they're going to want to wear them.
Want to buy them. They're going to want to use them. So if
Yeah.
you can morph them in a way that they're not kind of feeding into that hypervigilance, it would be helpful. Yeah.
So, does this pacing conversation become even more nuanced when patients are experiencing significant symptom flares after activity? Because I know for some kids and teens, post-exertional malaise is also a very real and complicated um, like balance between the re-engagement and overdoing it. So, how would you
Yeah.
address the post-exertional malaise when that's present?
Yeah. I, first, uh, post-exertional malaise, thankfully, we are learning much more about, and um, we have a much more comprehensive view that this is not just fatigue, it's not just deconditioning, it's not psychological, that there is real physiologic changes happening, that we are having impaired energy production at the mitochondrial level here. There's autonomic dysregulation that's a part of it. Our recovery, the physiology of our body's ability to recover from different activities is different in this case. And we see it in a variety of conditions, whether it's in our chronic pain conditions, of course, very frequently in our ME/CFS patients and long COVID, POTS, a lot of this kind of diagnostic overlap. We see the phenomenon of post-exertional malaise. And it can, at the beginning, seem very difficult, right? Because there's sometimes a delay to it. It's not always a very clear cause and effect. The symptoms can occur immediately, or they can occur, hours to days into the future. And so that can be a real challenge to read and react to for someone who's really trying to understand their condition. So yes, absolutely. It's actually quite imperative that we still use things like pacing and graded exposure to more active strategies when it comes to post-exertional malaise. We just have to be very mindful of how we do so in a careful and personalized manner. Now, how I will usually, if I see this as being a component of someone's care, this is where the whole person approach and really blending pain science and lifestyle medicine become pretty much a non-negotiable. And that is that we want them to understand that your body's alarm system isn't just your nervous system, right? That might be the boss, right? Your central nervous system, your peripheral nervous system, they are the troops in the ground. They're out watching and paying attention to all the things, but they communicate with everything from your enteric nervous system to your immune system to your endocrine and sensory motor. All of these different components of your body's alarm can be dysregulated. And that's what oftentimes we think is at the root of these changes in our mitochondria's response to exercise and energy production and our autonomic nervous system's ability to regulate. So we have to make sure that we are that we're feeding that root system, that we're making sure that we're providing the right um, foundations to allow their body to manage the physiologic response to a more active strategy to feeling better. So we have to make sure that their sleep physiology has been improved, and that we're focusing on anti-inflammatory and helpful approaches to nutrition and hydration, and that we are using things like mindfulness and stress reduction strategies that help to calm both the autonomic nervous system and our immune response. So that these are complex things, right? These are complex physiologic changes that are happening, but there's lots of little levers and dials that we can use to our advantage that opens the door to let them do more functional activities. And we know in the long run, activity, movement, these are eventually immunomodulating and anti-inflammatory and allow for that system to recalibrate itself. We just have to give them the right combination of environment and resources to let their body tolerate it.
I think you really just highlighted like that whole person care
Yeah.
that you use in this population is so important.
Yeah. has to be all the things, which makes it fun and complicated all at once.
Right. Um, so I think what really comes through in this conversation is just how nuanced and individualized pediatric pain care can be, and how impactful these approaches can be when some patients and families just start to feel truly understood. So before we wrap up, I'd love to end with something a little more personal and reflective. Um, could you share a patient story that you feel really illustrates the value of pain neuroscience education in this population?
Mm. Um, there are I love working with young people, and there are so many of them that come to mind. But this is a very, very recent story of a young person that I worked with, or I'm still working with. And she came to me via word of mouth about a year ago during one of her emergency room visits. They said the emergency room doctor said, "Hey, I know this person," and so she arrived. Her and her mom arrived on my doorstep, figuratively. She was going into her senior year of high school. Very bright young person. Um, uh, very hypermobile. Had 5 shoulder dislocations already, full dislocations, not just subluxations. Beaten a 9 out of 9. If you could give her 10 out of 9, we probably would have. Um, you know, long-term, many-year symptoms of dysautonomia, GI-related issues, and really challenged with daily functioning, right? She was on a home hospital. She was spending all but maybe 2 hours a day in bed. And the family was extremely supportive. Mom was extremely supportive. Had a really good developing understanding of kind of the physiologic things happening to her body. But they were very much still in that mindset of they needed to find all the ologists, right? They needed to find all of the specialists that would address everything from all the different root causes, right? And so they were really entrenched still in finding diagnostics and going to specialty clinics. And then at the root of it, from communicating with them, though, they felt really unheard. Right? They didn't feel like they were getting the support that they wanted. They didn't feel like anyone was hearing it. She'd been offered basically anxiety medications for years before they really recognized there were more layers to this. And it really gotten to the point where they were disenfranchised with healthcare and with her ability to get better. So, my strategy with them first is we had to get her functioning. So we started with some I call rapid relief tools. Like we really had to help her feel better. So some of those were just more lifestyle strategies to get her back at school, to get her upright, to get her, more hydrated and using some kind of volume repletion so that she wasn't having so much dizziness upon being upright. And that we can't underestimate the power of that. If you start to help someone feel better quickly, you have them, right? Like they
Yeah. Oh,
trust
yeah.
you because they felt better
Yeah.
soon. And then you can start to say, the long game,
Then
the
they want
part
to
that
know what
they want to know
next.
why. What else?
Yeah.
What else is there? And that
Yeah.
opens that door to the curiosity, right? The things that you can do. What else can you do for me if you made me feel better already? So sometimes just having some of those tricks up your sleeve of things that can make them feel better in the short term, those still matter, right? Because they give you, not only them relief, but they give you that opportunity to get their trust. And so then we started very, very carefully tiptoeing through learning about pain. She self-identified as being neurodiverse and said I've been to 3 different pain clinics and they all want to give me metaphors. She said that, and I don't want metaphors. And so I took a different approach, right? Where we really got into the science of it. She's a very bright young woman. And to make a long story short, she is in school. She's her last week of high school right now. We had a video
Wow.
visit few weeks ago where she actually found out she was accepted to a very prestigious UC school for,
Wow.
physics, in physics of all things. She's probably got
Oh
more
my
brain
gosh.
cells in her big toe than I have in my whole body.
Yeah.
Um, and is preparing to do all the things she needs to do to go off and be, a brilliant contributor to
Yeah.
our society. So they can change. They can really feel empowered to do the things they need to do.
That's so rewarding. And it just like illustrates like we can use this research that we have and really change lives. Like if she hadn't found you or someone, it could have just
Yeah.
easily led into adulthood and just
Yes.
missed those years of her life.
Yeah, we can do so much to set them up for success, right? And then
Yeah.
imagine how much better things can be for her and for anyone else around her, and her future kids if she chooses to have them. Like this can be impactful multi-generationally if we can get to, help them understand adaptive ways of managing their symptoms early.
Yeah. Thank you
Yeah.
so much for sharing that story with us.
Uh,
I think it looks like we have a few questions from the audience.
oh,
So, have you worked with pain neuroscience in a group setting? And if so, in a group setting, what is the youngest age group that you have taught pain neuroscience education in a structured approach?
okay, so kind of two parts to that. In terms of the group setting, yes, that actually is how I see a lot of patients, is a blended one-on-one and a group approach. I think the idea of shared medical appointments or group-based care can be very impactful and important, especially in kind of the realistic healthcare environment that we're in. So I run a program for adolescents and young adults right now, where all of we start their care on a one-on-one basis. We develop that relationship. We do a good thorough exam, and then we intermittently communicate and or have one-on-one sessions. But the bulk of what they're doing is in group sessions, and so we do both educational components and more active kind of group-based care where they come in and do a variety of strategies. I find that environment, that group-based care, is very, very helpful for the teenagers. So I find anywhere from like 12 or 13 to early adulthood is where I see them. They can really grasp it and they flourish in the social environment of it. Younger than that, group based is really tricky. I find it very effective for the family to be able to engage in group based learning that way, because there's an ability for them to feel camaraderie with other parents, right? And develop a sense of community with the parents. But kids younger than 10 or 12, there's so much variability in their ability to attend to group
Oh,
in groups, right? And to
yeah.
focus, that I personally find one-on-one care to be much more fruitful for them.
Okay.
Yeah.
Okay. So I think that's all we have time for today. Today's conversation really highlighted just how important it is that we continue evolving the way we approach persistent pain in younger populations, especially working with conditions like POTS, EDS, and other complex presentations, so that so often fall through the cracks. And Jen, thank you for sharing your experiences, your clinical insight, and I just really love like how compassion compassionate you are with your work. I know your audience is going to walk away with a lot of takeaways from this discussion. Um, and thank you, everyone else who has joined us today for another episode of Pain Science in the Trenches. Um, we really appreciate you being here and being part of these conversations as we continue to bridge the gap between pain science and real world clinical care. But before we wrap up, I'm excited to share that next month's guest will be Dr. Jessie Podlock, where we'll be diving into using pain neuroscience education and community outreach to support people with and recovering from substance use disorder. It's another incredibly important and often challenging area of pain care, and I think it's going to lead to a lot of more meaningful conversations. So if you enjoyed today's episode, make sure to follow along and stay tuned for the next one. Thanks again, and we'll see you next time. Thanks so much, Jen.
Christina, I really enjoyed it.